Siobhan's just joined, I think, Peter.
Okay, so we are all present, if not correct. Okay then, shall we begin? We can start the live stream, I think, whoever's in charge of that today. And welcome everybody, a warm welcome to the March board meeting of Sussex Community Foundation Trust. Today we are conducting our meeting by video conference online, and we're live streaming the meeting so that any of our governors, staff or members of the public who wish to view the discussion can do so, and they are also able to submit questions through the live stream. So also a warm welcome to anyone joining us on the live stream. Now we're going to start, as we normally do, with Employee of the Month and also Team of the Month to recognise some of the hard work and commitment from SCFT staff. And we're going to start, we've got Employee of the Month for January and February and Team of the Month for February at this board meeting. Now, if there is a common factor for our two employees of the month at this meeting, it is remaining calm under pressure. And I'm delighted, first of all, to welcome Selina Bailey-Brown. Selina, welcome back, as I said earlier on. And Selina is a community staff nurse down at Chichester, and she was nominated by our clinical services manager, Hannah Purser. And I'm going to read the whole nomination out to you because it's worthy of being aired. And it goes like this. On the 7th of January, Selina attended a patient's home to administer insulin, a normal routine visit. When she arrived, she found the patient in considerable distress about his health condition and expressing a wish to end his own life. Selina identified that he had the capability to do this by means of a live firearm with ammunition in his home. Selina reacted very, very calmly to the situation, de-escalating the situation with the patient, then administering the patient's insulin. She then called for help, and when help arrived in the form of a colleague, she bravely removed the firearm from the home and called the police, whose specialist firearms unit removed the weapon from the premises. She then communicated with other colleagues and initiated a multi-agency community response with the patient's GP to help keep the patient safe. This demonstrates Selina's huge courage and strength under pressure, as well as a patient-centred care and compassion. And Selina's response to this incident is particularly impressive because, as our board members may recall, Selina, you've only been in post since October 2021. So, yeah. Selina, very, very well done. It's lovely to see you again. And let's just put our virtual hands together for Selina.
Thank you.
So, Selina, you can stay if you want because it's a public board meeting, but you may have patients to see. We realise that. And but do come back and see us again soon.
I will do. Thank you so much.
Okay, thank you so much.
Bye.
Let's move on now to Employee of the Month for February. And I'm delighted to say that Sian Newman is with us. Welcome, Sian. Sian is a nurse advisor for the prevention assessment team down at Glebelands and was nominated by Mary Talman, who is a senior nurse advisor with the team. Now, Sian has been nominated because of her contribution to the team's ambitions. She encourages a healthy lifestyle through education and health promotion, and also demonstrates on a regular basis compassionate care. She is training to be a professional nurse advocate, I understand, and is passionate about well-being and prevention in health interventions, and is keen to help other members of the team through the education program she's going through. Now, Sian recently enrolled in a local park run, good thing to do. As she started, a fellow runner collapsed in front of her. She quickly realised the collapse was due to a cardiac arrest, and thanks to her calm manner, her knowledge and experience and leadership skills, she was able to start CPR and offer guidance and support to others who had stopped to help. Her quick actions and intervention resulted in the person being successfully resuscitated by the time that paramedics arrived. Sian continues to be a very productive member of the team, and just like Selina, calm under pressure. Very, very well done, Sian. I'm sorry that got in the way of your run, but clearly you were the right person on hand at the time. Let's put our hands together for Sian.
Thank you.
Thanks very much, Sian. As with
Thank
Selena, you're very welcome to stay. It's lovely to see you here. Your certificate, if it hasn't already arrived, I'm sure will be winging its way to you as we speak. Thank you so much, and thank you for all that you do. Now that takes us on to Team of the Month for February 2022. And I'm delighted to see Teresa Gaffin here. Now, Teresa, you're here on behalf of several of your colleagues, I understand, because the award goes to the care home matrons and the primary care network team leads in Bognor Regis. And this nomination, although it was made by Tony Hayes, the general manager, actually comes from the local clinical lead general practitioner on behalf of the team, from Louise Baverstock. And Louise says, I am keen to share how impressed I am with how the care home matrons have settled into their roles in Regis and are making a real positive impact upon the primary care network care home team. Specific areas of praise include the leadership skills demonstrated by the care home matrons in the multidisciplinary forum. It says they've stepped up and shown real enthusiasm to work together. They've worked hard to empower the care home staff and managers to become a valued part of the multidisciplinary process. There is no denigration of profession within the group, and total respect is given for each individual's input, regardless of role or position. This is an excellent example of a well-developed and robust PCN multidisciplinary process. Many congratulations, Teresa, to you and your colleagues. Please pass on our thanks when you get back to base. And again, let's just put our virtual hands together for Teresa and the team.
Thank you.
Okay, that's great, Teresa. I know it's a fairly new service down there as well, so very well done, and thank you for all that you do and all your colleagues do. And we wish you well in further developing the service down there. So thank you.
Thank you.
Right, that takes us on to the business part of the meeting now. And I don't think we have any apologies, do we, Zoe?
No, Peter.
I think the answer to that question is no. I now need to ask board members if they have any declarations of interest otherwise not on the register. No. Which takes us on to the minutes of the previous meeting held on the 27th of January. May I check any comments on the accuracy of the said minutes? I shall take your silence as assent and that we agree the minutes as a correct record. Which takes us on to the action log, and there is one action there which is down to the whole executive team by the looks of it, to provide more quantifiable outcomes in future corporate objective quarterly reports. That action's not due to May 2022, so I guess we will come back to that in due course. Everyone happy so far? Good. That takes us on to performance and assurance items and takes us on to the integrated performance report. And Mike, are you going to introduce this before handing on to other colleagues as we go through it?
I will. So thank you, Chair. As you can see, this is the integrated performance report. Importantly, for those not familiar with the report, we are looking here at the performance from January, and that's due to the kind of close down times to kind of verify data and go through our exec governance processes to make sure it's been validated. The January performance, as you can see, we're still reporting some areas of great progress and some areas of challenge still, especially in some of our operational metrics as a result of pressures experienced across the system over the last couple of years and how they built up into our waiting lists and other services. And just to note as well, we are and have been speaking about evolving the report to make sure that certain items where they haven't triggered a statistical variance, but where we haven't got assurance yet that we're going to hit the target. At the moment, we're kind of inconsistently reporting on those as an example. And so we will develop this report over the coming months to make sure some of those areas are routinely explored as well. But I'm sure execs will highlight any of those areas as they go through each of their sections. Sorry, Peter, you're on mute.
I did that just to save you the discomfort of being the first to be on mute. Thanks for that, Mike. I think we're going to go to the quality dashboard to start with, and Donna.
Thank you, Peter, and thank you, Mike. So you'll note from the quality dashboard that there are no exceptions this month. However, there are 2 in-month variations that I just wanted to highlight to the board. One of them is the percentage of incidents resulting in moderate harm or above. So the quality and safety team review all of our incidents just to confirm that the level of harm is correct and is appropriate. And so the numbers, the data is now showing that our percentage for that is 2.1%. So less than what's showing in the report, but still above the monthly target. So those incidents actually relate to 7 incidents. 5 of those are falls. 1 is a radiology incident and 1 is a category 4 pressure ulcer. So 4 of these are being investigated as serious incidents as well. The other metric that I just wanted to highlight to you was the number of complaints responded to within the timescale. So we closed 9 complaints in January, so each one represents 11%. Therefore, the 89% is representative of 1 complaint. So this is showing as not having been responded to in time. It was initially what we call a level 2 complaint. However, as that complaint investigation developed, it actually became a multi-agency complaint, so moved to a level 3. Therefore, the timescale change formed of that.
Is it just me, or is Donna frozen?
No, she's frozen.
Frozen.
Donna has just frozen.
Okay.
Peter, is it worth maybe moving on to the next section of the IPR,
Yes.
and we can come back to quality?
Come back to that. Yeah,
because I'm sure there'll be some questions.
let's do that, because we don't know how long we might have lost Donna for. So, Kate, are you ready to take us through the operational performance report, and we'll come back to quality?
Yeah, that's fine, no problem. Okay, so I'll just pull out the highlights and then stop for questions at the end. So first metric around average length of stay. It's been an upward trend in that since May 2020, but I'll pick up some more detail around that in the Spotlight report. I've included the West Sussex and Brighton and Hove HCP and LAC metrics, which goes back to Mike's point around these are sort of in-month exceptions, but because we've had sort of ongoing conversations about those through our board meetings, I thought it was helpful to add them. So the West Sussex Healthy Child Programme and the Brighton and Hove Healthy Child Programme were particularly hit by COVID absences in January, both for staff and the COVID impact on families cancelling appointments. That impacted on the West Sussex team in particular being able to hit the target, although you'll note from the narrative that the total number of children seen outside of the time frame is now at 95.8%, so above the target, but it missed the 10 to 14 day time frame. Brighton and Hove, whilst impacted, were more able to maintain their performance against the target, and that's just because of the health visitor to family ratios in Brighton, and also the more compact nature of the kind of geography means that the teams are more easily able to cover for each other than they are in some areas of West Sussex. And LAC similarly remains above target. And Leslie, I know you asked a question about this last time, but the assurance around the peaks in demand and whether we will be able to sustain performance against target when we see a big peak in demand is still uncertain. So we're looking at different ways to manage activity, but it remains quite tricky when we get a batch of children needing to be seen at one time in terms of how we manage that against clinical capacity. Moving on to the time to talk access target, that's an improving position, and you can see the actions that are being taken there in terms of increasing both clinical capacity and increasing the referral rate. So I'm happy to take questions on that, but won't go into any more detail now. If we move to diagnostic weights, this is a similar position to previous months. So the East area have met or almost met the target across all the units. Audiology was particularly impacted again this in January with COVID, again, both on children needing to be seen and on staffing, but that position has now recovered. So ultrasound remains the biggest kind of factor impacting on performance against that target. And you'll remember in previous months, I've advised that we are bringing online some additional capacity in Bognor. That's coming online as we speak. The longest wait you'll see from the narrative there is 12 weeks currently, but we're expecting to meet that target in May. So that's again an improving position. If we look at RTT weights, 79% performance in January. As I've said previously, the majority of those patients are within the West Sussex MSK service, with a smaller number of patients in chronic pain and rheumatology. Chronic pain and rheumatology have both shown an improved position for January. And the MSK service have a plan in place to reduce their 35+ week waits by the end of April, and they've got a waiting list initiative in place to increase capacity and bring those waits down. Dental are still performing below target, but again, an improving position at 86.3%. And as I've discussed previously, they've got a waiting list plan in place, which will see them recover by January 23. That's related mostly to general anaesthetic availability, and we are now working with partners to increase the availability of GA slots. The child development centres are performing overall at 91%, but you'll see from the narrative that there's variability between each of the centres. They also now have a plan in place to reduce their longest waits by July, and that's through, again, bringing in some additional locum staffing capacity. Peter, I propose to pause before I move on to the Spotlight report and just take any questions on the metric data. Is that okay?
Yeah, that sounds good, Kate. Quite a lot in what you've already said.
Yeah.
So questions from board members. Mark, followed by Leslie.
Yeah, thanks, Kate. So clearly the ultrasound machine at Bognor is a key element in relation to that, getting that diagnostic weights piece down. You said it was coming on stream. I just wondered, given the intent was by the end of March, is it operational now? Or
yes.
If not, when will it be?
No, it is operational now, but we're only just starting to kind of see the activity going through there. So it's on track. It arrived on time and it's operational, so in place.
Thank you.
Okay, Leslie, followed by Rebecca.
Thank you, Peter. I can confirm that, Mark, because what I was going to say is I was down in Bognor this week and saw the new machine there installed. But what I was particularly impressed at is the training of some of the new stenographers that are coming through, and how the existing staff are supporting those to gain the experience that they need. So I was really quite impressed with that. So thank you.
Thanks, Leslie.
Rebecca.
Thanks, Peter. Hi, Kate. Yeah, quick question just on the average length of stay, which obviously, as you've said, has been going up, and I know that's a trend that's happening all across the country, so not unique to us here in Sussex. It was just, and maybe you'll pick this up at the end in the spotlight, I was just intrigued to understand a bit more around the context of the the delayed discharge and the operation reset, the pilot that happened, and just whether that was successful. Is that something we want to continue with, and just what positive impact we could see from kind of continuing with that?
Okay, thanks, Rebecca. I'll move on to the Spotlight report and then I'll pick up the answer to that question. So we've just added a bit more information this month around average length of stay. And I guess the key message is that there's two contributing factors to average length of stay. One is the actual length of time that patients need to remain appropriately being cared for in our beds. And the second is the impact of what you've just described, Rebecca, which is patients who are actually ready to be discharged, but the next stage of their care isn't available. And what we've seen, and what you'll just see from the graph there, is that whilst the average length of stay for patients who are appropriately in our beds and need care from us has increased, and that's to do with the complexity of patients that are coming into the beds now, and the length of time that those patients need our care. What's also happened is that the impact of the length of time that patients are delayed in our care is a bigger contributing factor to the average length of stay than it was a couple of years ago. And that reflects certainly a regional position, but also a national position around predominantly availability of domiciliary care and care home or residential care home provision. So you're right, Rebecca, we did do the operational reset. What we found from that was that flow improved. So we were the kind of multi-agency and real focus on discharging patients and finding alternative provision, or trying to really look at where, for instance, the voluntary sector could support. That really kind of helped us get patients through the system. It didn't actually change the fundamental bottom line numbers, because as fast as we were discharging delayed patients, we were seeing more delayed patients come onto that list. So the overall position within Sussex didn't change significantly, even as a result of Operation Reset. And we are having ongoing challenges in Sussex around, as I say, availability of care and domiciliary care providers, with a number of specific issues in the area regarding providers who are going out of business and having to hand back care hours. So it's an ongoing challenge for us in Sussex.
Before I bring Giles in, Kate, do we notice variation in those pressures across the different local authority boundaries? And, you know, is there anything we can learn from one to the other, for example, in terms of where we are having some success?
Yes, so we do see differences across local authority boundaries, but not consistently. So we'll have periods of time where it's worse in West Sussex and periods of time where it's worse in Brighton and Hove or East Sussex. What I would reflect is that our local authority colleagues are working very closely together in order to try and learn from each other and to try to standardise where initiatives are being put in that work well, how those can be transferred across areas. At the moment, from our perspective, we're seeing a particular issue in the Brighton and Hove system in respect to delayed discharges, with a large proportion of our very delayed patients waiting for adult social care from Brighton and Hove City Council. Yeah. Siobhan's put her hand up, so she might.
Yeah, Siobhan, do you want to come in on this one?
Yeah, I was just going to add, I was part of a national conversation yesterday with the NHS England chief executive and senior team, and there is cross-government focus on what the solutions need to be at national level. So although Kate's really aptly described Sussex and almost the pendulum of pressure swinging from one local authority area to another in any given month of the year, the fundamental issue I think for us is that for pretty much the last 12 months consistently, at least 25% of our beds and 25% of our responsive services placements have been occupied by people who need an onward care package or placement. And it's just no longer sustainable to think about only focusing on local solutions. You know, the teams are working really well on the ground. My ask of the national team yesterday was that there is recognition that a much more radical reform of the care sector is needed in order to kind of change the pressures that we're feeling, because whatever has been tried locally has not shifted the fact that for us, 1/4 of all our beds are occupied with people who should be somewhere else. And that hasn't changed, irrespective of focus on operational reset, redeploying staff, working differently. I think that's been the legacy of the second year of the pandemic, which is the reality is a combination of factors have really negatively impacted on the care sector, particularly in our region. And there needs to be a more radical reform agenda for care, not least of which starting with terms and conditions for the people who work in the care sector to make it a more sustainable and an attractive proposition. So I fear that no matter how hard we work locally, no matter how much we work in partnership day to day, without that radical reform agenda, we just don't seem to be able to make any difference to the pressures that we're experiencing. So just to add, I am talking to whoever frankly will listen about the need to recognise that we can't continue in this way without a more fundamental reform of the care sector. Now, I know that's easy to say and difficult to do, but the health and social care levy is being introduced tomorrow, and I think there needs to be an expedited view about how much of that goes to the care sector rather than how much of it, or rather than how long it will take to get there. So I think we need to, and I'll continue to lobby for more fundamental change at national level that hopefully will improve the situation. But whatever we have done for a year, when you look back at the figures, we've never been under this much pressure around medically ready for discharge patients being unable to move on to their next kind of care pathway.
So what you're saying, Siobhan, is everyone is pushing as hard as they can. We've used all the tools in the box and we're still not moving things very far. Obviously, we will continue to push as hard as we can, but we need some more structural reform. And next winter isn't that far away either, is it, when pressures are at their highest? Yeah. OK, let's bring Giles in.
Thank you. No, I do appreciate all the pressures there. And of course, what that's focusing on is, if you like, the plug hole that's letting all of the pressure out of the system necessarily and how blocked it is. But equally, if you look at the increase in care time that we're given over the period that looks like on the chart on page 29 of the pack, it seems to have gone from about 12 to 18, which is an increase of about 50%. We seem to use a term called complexity to try and justify that. And that came up several times when we were talking about hospital at home when Stephen visited the other week. And in some ways, it just feels like a bit of a blanket term of complexity. So does that mean that the acutes are releasing people who are more ill in the first place and we're taking them on who are more ill in the first place? Is there a different perspective around what it is that we're trying to treat? Or have we raised the bar at which we're able to say somebody's medically ready for discharge? It just feels like something has shifted in that space of either there's a lower bar for entering our system or a higher bar for leaving it, unless something has fundamentally happened around the illness of people in 2 years.
Giles, if it's okay, I might, yes, Sarah, I was going to say, I'm sure Sarah will probably want to come in on this one from a clinical perspective.
So I think the complexity is, if you think about what's happened during the pandemic. So first of all, there are people who've actually had COVID, which has prolonged people's lengths of stay. That's varied throughout the pandemic, from it causing much increased length of stay in the first part of the pandemic and is a bit less of a problem now, but still impacts. The other thing that happened is, because of lockdowns, particularly elderly people, I think, became very deconditioned because they didn't go out as much, you know, because they weren't allowed to. And so I think that that's caused some problems with when people actually come up to hospital, they're coming up to hospital in a deconditioned state. I think there's also been an impact of the fact that people didn't actually seek medical help in particularly in the earlier parts of the pandemic, which has meant that people have presented at a later stage of illness, which would also impact. There's a fourth point that I was going to make. I think those are the major points. There is another one that's just sort of gone out of my head, but I think there's lots of reasons why people, patients may not do. The other thing is actually the impact of waiting. That was the fourth point I was going to make. So the impact of waiting is that waiting for longer for social care is that that people can become more deconditioned as a result of waiting, whether that's, particularly actually in the acute sector.
That's really helpful, Sarah. There's a really good insight. And so do you think we're now at the peak of that as we're coming through, and we can expect that orange line to start coming down again? Because those complexities that you listed are almost directly related to pandemic function. So as people are getting out more, as people are more ready to present themselves with illnesses, could we expect that orange line to come back down again to where it was?
I think eventually, but I'm not sure that it will necessarily be quick, because I think there is still the ongoing, we know that there are a large number of inpatients in hospital with COVID at the moment, about half of whom go in with COVID, half of whom are identified as having COVID when they present with another type of illness, but less people are going to ITU, so there are very few inpatients nationally on ITU with COVID, but there is still a kind of, if you think about the kind of backlogs that there are in care for operative procedures, for example, then elderly people, particularly if we're thinking about the elderly, then people who might have had their hip replacements done within 18 weeks are now sometimes waiting for more than 52 weeks, and in some cases more than 104 weeks. So I think it's not. I think it's not going to be quick to get back to a more normal situation.
Thank you, Sarah. Thank you, Peter.
Thanks, Giles. Yeah, and I think we've made an attempt to distinguish, haven't we, Kate, between underlying increases in length of stay because of delays and because our patients are more poorly or have additional complexity in their healthcare needs. Yeah. Okay. Any further points you want to make on the issue of discharge, Kate? The spotlight on this is going to continue, I know, throughout the year. So it's going to be something undoubtedly we're going to come back to as a board.
Yeah, absolutely. No, I haven't got anything further to add, Peter. Thank you.
Okay. Anything further on the operational services report before we leave it? Okay. I think we have Donna back now. Am I correct? Are you with us again, Donna?
Peter. Thank you. I'm so sorry, everybody.
That's okay. I guess it's not your fault if the IT goes down. I think we got up to the complaints bit. You were explaining different levels of complaints and explaining the figures behind that. So shall we sort of take up from there?
Yes, so it was just to finish off what I was saying, in that this metric relates to just one complaint. That was, the timescale has changed because during the investigation of the complaint, it was noted that actually it's a multi-agency complaint, so the timescale gets extended. So it's showing as not being responded in time, but actually we will just amend the timescale and then that will be amended for the next IPR report. And just to note, the complainant is obviously kept fully informed around the timescales, so we're managing expectations there.
Okay, but there's an important general point coming out of that, is when it comes to that percentage, it seems it's very sensitive to small numbers or small changes. That's the thing we need to know on that. Yeah. Okay. Leslie, do you want to come in from the perspective of Chairman Quality Committee on some of what you've heard today?
Yes, thank you, Peter. And thank you for giving those verbal updates, Donna, because I was concerned that there were no quality exception reports. So the advantage of having the exception reports is that you get the SPC charts. So one of the questions that I wanted to ask you, and I think we touched on briefly but didn't get a resolution on, was around those patient safety incidents, because obviously the number's gone up and you've explained that. But is that a one-off blip, or has that been a steady trend? Although the year to date is still low and within the target figure, are we seeing a trend of increasing moderate harms within incidents?
No, we're not generally, Leslie. I mean, obviously, when you look at the charts, the number goes up and down, but the general trend is relatively stable.
Okay, it'll be useful to see an SPC chart. The other thing that I wondered if you'd like to update the board around, which I touched on briefly in my chair's report, but isn't in here, is around infection control, because there's been quite a lot happening, and I think it's very pertinent that the board knows what's going on.
Yes, of course. So we continue to have a number of outbreaks that we're managing. We currently have 6 open outbreaks in the trust. 2 of those are outbreaks where all of the patients are considered to be COVID recovered. So whilst we still monitor them, the wards are deep cleaned and they are open again to admissions. What we are trying to do, however, in relation, just to kind of align with the conversation you were having with Kate earlier on around operational pressures, is that we try to be as flexible as we can around admitting patients and discharging patients as safely as we can from an IPC perspective. So we try to cohort patients and staff where that's possible. The national guidance around COVID has changed, so patients are considered COVID recovered once they reach 10 days rather than 14 days. So we test to make sure they're non-infectious, and then we consider them COVID recovered, and we therefore can admit and discharge. So we're doing a very sort of dynamic process really with managing our outbreaks, working with the system, because obviously we're sharing the same challenges as our acute providers as well. But it does continue to be an issue. We have recently seen a slightly different pattern in the outbreaks, in that the outbreaks are lasting for longer, and we're having higher numbers of patients involved in those outbreaks. But we think that is generally related to new variants of COVID, but also the significantly high community transmission rates that we have in Sussex as a whole.
Thanks, Donna.
What's the forward look on this, Donna? Because you mentioned those very high transmission rates in the community, which obviously impacts on this, and clearly this has an impact on our ability to take patients through the system. You know, what's the sort of, you think this is going to go? Is it going to slow things down for us in that we're going to have to cohort patients for the foreseeable future, for example?
Well, potentially so. If we continue to have outbreaks of people who are infectious, then we have to do the right thing for those patients and protect those patients and the other patients on the ward. But I think so I can see Sarah's got her hand up, but the profile of a pandemic can be up to 5 years. So whilst the numbers will obviously gradually decrease over those 5 years, we will have peaks within that 5 years. Those peaks we would anticipate would be lower than the peaks we've had in the first 2 years and probably last longer. So you'd see a sort of elongated pattern of a curve rather than a sharp curve. But I think we do need to expect and anticipate that that's what life will be like really in the NHS over the next couple of years at least. We are anticipating new national guidance coming out very shortly, literally the next week or so, which I think will look again at some of our IPC measures and what we know now about the transmission of COVID. So obviously when that comes out, we'll review our practices and implement any changes where we need to. But I think that the general principle around isolating patients who are infectious, we can't move away from that, and we do still need to expect that will be a factor in healthcare for the next couple of years.
Okay. Anything else you can cheer us up on, Sarah, on this issue?
No, I mean, I guess although we've got less people in hospital and less people on ITU, we've probably got the highest just about the highest numbers of patients in the community with COVID at the moment than we've had throughout the entire pandemic, partly related to the Omicron BA.2 variant being even more transmissible than Omicron, which was more transmissible than all of the other variants. And it's just a good job that our communities are vaccinated and boosted. At the South East Regional Medical Directors meeting on Monday, there is a sort of anticipation that we're currently in a phase where the rate of growth of cases is starting to slow down. And it's thought that in the southeast, which has actually had some of the highest levels during this phase of the pandemic, which has been unusual throughout the pandemic, that they're starting to show signs of plateauing. And it is thought that the Easter holidays will have an impact on starting to see numbers come down, and also improvements in the weather. Also, because people are indoors less, starting to see numbers go down as well. Because obviously there's been an impact of the less social distancing, no mask wearing, etc., etc.
Okay, thanks, Sarah. David.
So I was just trying to work out how to go off mute. So just to pick up what Sarah was just saying, the question I was going to ask you was actually the opposite of one of the things that you've just said, because I've seen somewhere a suggestion that the COVID rate might very well increase over Easter because of more sort of mingling and therefore more of an ability of the bug to sort of spread. That's clearly not what you're hearing.
No, I think they think that so what seems to happen is every time, just because as you might be able to tell, I'm a little bit obsessed with the data on this. But what seems to happen every time there's a school holiday is that the numbers go down.
Okay.
And I think the only time that was different was around the Christmas of, I've lost track of the years now, not last Christmas, but the Christmas before, when everybody had been so locked down, and it was obviously December, and then they kind of hurriedly put back in some kind of control measures. I think that's the only kind of holiday period where numbers actually then, because obviously we then had the issues of late December and the peak of infections at the beginning of January 2021. But most of the rest of the time the holidays have caused a reduction.
So a glint of light on the horizon, I'll take from that. Before we move on, in terms of action, the issue about making sure we have the trend data through SPC charts on issues like patient safety in future IPR reports. And maybe, Leslie, you and Donna could have a look at that and help us understand as best we can what's going on. That's great. OK, let's leave quality. I think workforce is next.
Thank you, Peter.
Morning, Caroline.
Can you hear me OK?
I can hear you fine.
Great. So just a few things to note on the IPR. I will pause for questions before I talk about the Spotlight report. But just following on from the conversations that we've just had, it's worth noting that the Trust continues to experience periods of high levels of sickness absence relating to COVID. We've had another peak in the number of absence due to staff being COVID positive. We had a peak in January. We've had another peak just recently, which is starting to reduce. The levels have not been experienced those levels have not been experienced for a very long time. So the pandemic is continuing to impact not just our patients, but also our staff. I think this is obviously adding pressure to our teams who are experiencing high levels of sickness absence and trying to recover the backlog that has built up during the first parts of the pandemic. So the pressure on teams is evident, and I think that although our KPIs are showing sort of positive trends in some ways, we do need to recognise that. So the second thing I was going to say is that the new people committee, which is starting formally in April, will receive reports on the metrics that drive the performance in the KPIs that are shown in the IPR. And I think that will give the board more assurance about the drivers underneath those high-level KPIs, both in terms of attraction of new staff, but also being able to give people a career that what makes them want to stay in the organisation for longer, how we support them, and obviously with a golden thread of inclusion running through all our discussions. So we are building those metrics at the moment, and I think that will give the board much more information and assurance in the coming months about what's happening in the organisation around our workforce. And Giles may want to comment on that, but I thought it was worth mentioning. The last thing I was going to say is that targets, just like measures, I think we talked last time about KPIs such as turnover rate, which are not always helpful in understanding our performance, will be reviewed along with targets. This is important in the context of service expansions and also changes around the vaccination programme, which obviously has impacted on things like turnover, vacancy rate and staffing post numbers. So there is more work to do around that, but I will be keeping you updated, and I'm sure this is something we'll talk about at People Committee as well. So these were the three things I wanted to mention. I'm happy to take questions on any aspect of the report, but not the Spotlight report. If you could keep that for in a moment, that would be great. Thank you.
We will try and control our enthusiasm for the Spotlight report. Before I open it up, this question may be more for Siobhan. I know there's been a lot of concern amongst staff about the availability of lateral flow tests, which we asked them to take twice a week. And there was some correspondence from NHS England about that yesterday. Is there anything you can advise us on that, Siobhan, that will help understand what's going on?
Yeah, thanks, Peter. So you're right. We got a letter yesterday that made it clear that for NHS staff who are patient facing, they are still required to undertake lateral flow testing twice a week, irrespective of whether they have symptoms or not, to ensure that any risks around spread of COVID for people who are asymptomatic in the NHS workplace are mitigated. So we're just in the process of going through the letter to get the communications out more widely into the organisation. The gov.uk supply portal for lateral flow tests does recognise it does recognise NHS employees, so you can register with an NHS email and log your organisation. And a couple of us were looking at that yesterday, and it does seem to be already updated to enable anybody who's ordering to be recognised as an NHS employee. If people are symptomatic and NHS employees, it also enables people to order the lateral flow devices on the gov.uk portal. So it's a more promising position than before we had the letter confirming that. And I know that Kate and the Silver Command team are just finalising the communications today to make sure that everybody's clear on the process from the 1st of April, which is obviously tomorrow.
Okay, thanks for that, Siobhan. Workforce report, any questions for Caroline on what you're seeing? Giles?
It's more comment as much as anything really, Peter, is we had a very good session earlier this week looking at what the figures actually look like under here, trying to examine the data quality and timeliness that we're able to bring through that's actually relevant to what it is that we're looking for to be able to bring that assurance that we want at this level. I think that there are some particular challenges around growing a workforce and the balance around retaining a workforce. And so there is a piece around attracting people from outside SCFT, attracting people necessarily from outside the NHS. And I think what's really key to that is opening up the opportunities and understanding really what the attractive offer is that says, let's make SCFT specifically the employer of choice. And that is, of course, I think, around in quite a competitive market that we're in, engaging with the universities, as we saw with the two people who came to the last board, their story around what recruitment looks like, and maintaining those offers that attract people, such as apprenticeships for those that it's relevant for, the opportunity for advanced clinical practice that is absolutely key for retaining staff who are valuable to us within that as well. So the first deep dive that we're going to do is look at the first bit of that around what does the attraction piece look like, but also kind of what the speed of recruitment is, because there's sometimes a time lag between the offer and being able to enter the organisation, and absolutely about trying to make it relevant, keep people warm, and that whole onboarding experience of feeling welcomed and wanted.
And a really important point you draw out there, Giles, in a world of workforce shortages, we need to look beyond our boundaries and beyond those of the NHS to attract people in. I know we've had discussions about that before, Caroline. Any other comments or questions on this at this point in time? Caroline, can I ask you one more question? The information you've given us gives us a good view of the overall position, but help us understand in terms of where we are today, what the particular pressure points are, where the main concerns are around not having enough people, which we read about in the press for the NHS every day. So I wonder if you could just give us a little bit more of an insight into where we're most concerned at the moment.
Yes, thank you. And Kate may want to add to that for her services, but I think what Giles is describing is right, that we need to think beyond the traditional jobs and the traditional route of coming into the NHS. The vaccination programme has taught us that. So the pressures, some of the pressures are easing. So we know that our international nurses have gone some way in reducing some of the workforce pressures in our bedded units, although not equally across the whole organisation. It's starting to have an impact. But there are still shortages in community services, in school nursing, in health visiting. So the staff shortages that we know of, that we've been talking about for a long time, are still there. I think that as an organisation, we've when you look at the data, it's interesting because we've expanded our services hugely, and we have kept on top of our vacancy rate. So although we still have gaps, and we probably have the same gap that we had a couple of years ago, actually that's in the context that we've actually recruited more people and more people are employed by us. So there are differences. We looked at that by area a couple of weeks ago, and we found that some areas are actually gaining staff, so they're having a net increase in the number of staff working for them. But again, these are we're still expanding further. So I think the gaps and the shortages are the ones that we know about. There are specialist skills that are missing for us around, for example, podiatry and various other things. But what we need to do is think, as Giles said, around using the local universities to think about apprenticeship, for example, in podiatry. How do we make that happen so that we can create those roles and bring those people in our organisation? So there are opportunities for us to think differently, think beyond the established pathways and recruit more people. But Giles got his hand up, so he may want to add to that, or Kate.
Okay, Kate, do you want to come in first? Anything you want to add to what Caroline's told us?
Yeah, I mean, I think just to add to that, we're having conversations with all of the areas about properly looking at what tasks it is we need people to carry out, and then who we need to recruit in to do that, so that we're sort of trying to move away from just replacing like for like, and particularly looking at elements of a clinical role that potentially could be carried out by an administrator or a management type role, so that we can try and relieve the burden on our clinicians and properly focus them only on doing what only they can do. So we're kind of having those conversations. And just to add in around health visiting, there's a regional, and school nursing, there's a regional meeting. I think it's been delayed until May, but really looking at what we're going to do as a region to address the health visiting and school nursing vacancies, because it is a particular issue. And I think as part of that conversation, they'll also be looking at similar things. You know, what is it only a qualified health visitor and school nurse can do, and where could we look at bringing in additional roles and different roles to do some elements of that work. So ongoing discussions. Okay,
thanks, Kate. Do you want to come back, Giles? You're on mute, Giles.
Thank you. Two quick things, if that's all right. Just quickly on the back of what Kate says there, I really welcome that, the clinical focus on it. And the bit I'd add to it is using people at the top of their clinical expertise and stretching that capability has to demonstrate the best use of their capability and the investment that we make in them. The second bit was actually, as we were talking through the performance figures, was around diversity and inclusion, Peter. And this debate of, do we treat it as a kind of a separate measure that we want to do, or do we want to treat it as a golden thread that goes through everything? And I'm always slightly torn, because if you count it separately, it stops being everybody's job and it's somebody's job over there. But if it's a golden thread, you can sometimes lose sight of that. And so absolutely, we're alive to the dimensions of kind of around how we make diversity inclusion everybody's responsibility within the organisation. It's not just a function of HR.
Yeah, no, thanks. That's a very important point, Giles. Thanks for raising that. OK, let's move on now, shall we, carry on to the report on staff survey. And the national staff survey results were issued yesterday, I understand. I don't know if you've had a chance to digest them yet, but perhaps you might be able to give us an overview. I don't know.
Yes, thank you, Peter. Leslie's hand went up, so I didn't want to start talking unless Leslie was happy that.
No, that's fine, Caroline. Carry on. Okay.
Sorry, Leslie, I missed that. You've disappeared off my list for some reason.
So as you said, Peter, the embargo was lifted yesterday, which means that we've now been able to start looking at how we benchmark, how our results benchmark across not only our sector, but the NHS as a whole, and also locally in our ICS. I think what I would say is that we are still looking at the results. There is a lot of information to get through, but we have got some key highlights, and I think I should hand this part over to our chief exec. So Siobhan, could you take this bit, and then I'll take any questions and add a little bit at the end, if that's okay.
Okay, the buck has been passed, Siobhan.
Yes, absolutely. I mean, the board will be aware that I care obviously a lot about what our people tell us, and so I just wanted to kind of give a couple of reflections, and Caroline's done a great job on the summary slide, I think, to kind of give you a fairly balanced perspective. But so just to start on the response rate of 73%, we now know that in our sector, in the community sector, the national average was 61% response rate. In Sussex, the best I can find, and we're still mining the data, but the best I can find as a response rate for an acute trust that's top of the response rate table in their sector is 65%. So as it stands, we believe that we have the best response rate in Sussex. We think we're second nationally in our sector around response rate. But importantly, what that means is, as the slide says, you know, the results that we have are from more people that have ever engaged with us to tell us how it feels to work here. And so 3,886 people giving us their feedback in the second year of a pandemic, I think is a phenomenal result and a really good sign of engagement and a culture where we seek people's views with real meaning. And it also gives us a wealth of data for us to be able to focus our action plans for improvement on over the next year. So the first thing is that. In terms of benchmarked data, as Caroline said, we're trying to kind of look more widely than the community trust sector. So I just wanted to give you some insights around the metric that is our staff would recommend an organisation as a place to work. So you'll see in the slides that that there's been a slight decrease on the 3 key metrics that are often drawn out of the staff survey and used externally as benchmarks. There's been a slight decline for us from 2020 to 2021. That's a national trend that's been fairly well publicised. And I think will continue to be a discussion point. The reality of the second year of the pandemic is, as we've said to board members, it has been attritional, it has been exhausting, it has been relentless. And actually, the second year of the pandemic has been far more complex now that we look back than the first year of the pandemic. So the first year of the pandemic was full of risk, uncertainty, safety concerns, and a range of supply issues, both, I guess, around PPE in the early days, and then latterly vaccine as we moved into the vaccination programme. But it was all quite singularly focused around managing the pandemic. And I think what this last year has shown us is that the recovery of services, everything that Kate's described in terms of operational complexity, everything Donna's described in terms of infection prevention control, and everything Caroline's described about workforce has all really come together in a really, really challenging way. So I think the context of a slight decrease is expected. There are a number of organisations that have seen a fairly dramatic decrease in their scores. So I'm very pleased that we've held within a couple of percentage points those 3 headline metrics. I'm also really pleased that our engagement score has remained at 7.3. To not drop on an engagement score in the context of what we've been dealing with is really pleasing. I think we often look across sectors and we look at the southeast of England as a benchmark now as well. Colleagues will remember last year we were the highest performing. When you look at the aggregate scores, last year we were the highest performing trust in the Sussex ICS. We haven't had that validated yet, but at first impression, Caroline and I think that we probably are still in that place where we are across the aggregates, the highest performing in Sussex. When I look at the southeast of England across acute, ambulance, mental health and community, there's 24, I think, organisations that in terms of would recommend an organisation as a place to work. I know that there are 4 organisations above us, and that makes 19 below us. Without seeing the table composite, the mining I've done on the data that's available, the highest in the southeast on that metric is 74. So there's a 74, 73, and there's 2 at 72, and then there's us at 70. So I just wanted to kind of give a bit of a balance, which is, of course, there's always things for us to work upon. I think the people managing their work pressures, morale, feeling energised to improve their services is most definitely something we need to work on moving forwards. But I think as some of this gets published through various national health media and regional tables, we'll have a bit of a better understanding about the wider benchmark. But the early indications from what we've seen yesterday and this morning is that holding the level of scores we've got and increasing the staff response rate by the 10 percentage points that we did is a very good place to be in the context of everything that I've described before. So I'll probably pause there. I can see there's some questions. So Peter, I'll hand back to you. You might need to just take yourself off mute, Peter.
You shouldn't make the same mistake twice, really, should you? I was going to say, you could probably carry on talking about this. For those who haven't had a chance to look at the overall national position, it is, in general, a deteriorating position. You know, for example, only 59.4% of staff said they'd recommend their organisation as a place to work, which has gone down by 7 percentage points on the previous year and is back to where it was in 2017, I understand. So that, unfortunately, is the overall position, which some people may not find surprising given we're coming out of a pandemic. But it'll be interesting to see some of those comparisons, Siobhan, but also where we're going to concentrate our efforts as we go over the next 12 months to learn from the results of this. I'm going to go to Dipesh first and then Rebecca.
Thank you. Thanks for that, Siobhan. And as you said, it might be too early, but I think you mentioned that the 3 questions that you pointed out, the trend is lower nationally, and other trusts probably have a more dramatic, their trend line is more dramatic than ours. But were there any sort of metrics where our trend line is more dramatic, so there's more concern relative to others? So not looking at it on an absolute basis, because as you said, there's always things that we can improve, but more on a relative basis. Is there anything that you saw or came out to you that you think, we are relatively trending worse compared to others?
I mean, there's nothing below the average for any of our composite scores, Caroline, is there? There's nothing that trended below average. We were either at the average trend or better than the average trend. But Caroline, in the subsections, was there anything that you and the team picked up that looked more of an outlier than the headline people promised themes?
Thanks, Siobhan and Dipesh. No, so I think that you're right. We either follow the trend or we're better than the trend. So in particular, one area for us which has improved in line with the trend around managers in particular, we've improved, but we've improved more than everybody else, which I think is really good. I think we should be really proud of our managers who are across the board really supporting their staff in a completely I wouldn't say in a new way, but I think the pandemic has really reinforced the need for managers to work with their teams and support them and listen to them, and that's been demonstrated. So on my immediate manager encourages me at work, for example, the trend is upwards, but actually we are better than the trend, and we're doing better than even the best performing trusts. So there are some really good pockets of positive news. And there's nothing that I've noticed that has where we've declined and others haven't, if that makes sense.
Yeah, that makes sense. Thank you. Thanks.
Okay, Rebecca.
Thank you. Yeah, well done to everyone. Obviously, massive applaud to everyone for all the hard work to get so many people to participate and so on. I just wanted to pick up on the point. I think the one area that slightly concerned me was the question around whether if a friend or relative needed treatment, would you be happy with the standard of care provided by the organisation? And I think if we just tie it back, obviously, to our strategic vision as an organisation, which is all about excellent care at the heart of the community, there just seems a slight disconnect. And obviously, Siobhan, totally recognise what you've said about the challenges of the pandemic. And Caroline, you said about the themes underlying. And I guess it's just assurances that we continue to monitor that and that there aren't any other themes coming through, because I think we could be quite complacent to say it's as a result of the pandemic. But it would be good to understand and unpick the data, if data is available, to understand what was driving people, because almost a quarter of people don't feel comfortable to recommend the quality of the care. So it was just a point on that for us to dig into that data a bit more, I think, on that specific question.
Can I come back quickly on that? Is that okay? So looking at our results, we are back to the score that we had in 2017. So we went from up, and then down back to 2017 results. We know that for some of our services, in particular children and specialist services, where some of their work was paused or altered during the pandemic, staff have fed back that they didn't feel they could deliver the care they wanted to, and therefore that impacted on their recommendation as a place to receive treatment. But I agree with you, we need to focus on that. And one of the things that I wanted to say was that we, as you know, there's also a quarterly survey that's done in the NHS. It's called the Pulse survey. And for Q2, we're looking at doing it very differently with focus groups and a more live discussions around the experience of staff. And so these are the sort of things we will be digging in with people about their experiences and what would make a difference to them around that question and others.
Okay, thanks, Caroline. And Mark.
Thank you.
Thanks, Peter. Yeah, echo comments. I think Siobhan, the response rate speaks volumes for the focus that this has, and there's clearly a very good set of results. I was smiling to myself when I was reading some of the national stuff this morning, because the journalists will lead on what the story is. So one of the headlines I read was only 27.2% of staff think there are enough staff in their organisation, and it just led me to think, clearly we compare ourselves with benchmarks and look at trends. I'm interested in, where are we scoring on an absolute perspective, lower than we want to, and that might be having an impact on morale or other things. And we can explain it with the pandemic and workloads and all the other challenges. But I'm just interested in, what are those areas where you look and think, regardless of how others are doing, that's just too low for us?
Yeah, absolutely. I mean, I think there are two things. One is staff wanting to leave the organisation. That is nationally 31.1%. For us, it's 25.2%. So we are exactly as you described, we're lower than the average, but actually a quarter of our staff wanting to leave the organisation is far too high. So we do need to focus on that. The other thing is that what we found through our analysis around disparity of experience between staff groups, so BME staff and white staff, or disabled staff and non-disabled staff, is that we're making progress in that the numbers of staff experiencing discrimination or abuse is reducing, but the gap is still too significant. So the difference between the experience of a member of staff who has a disability and one who hasn't, the difference between the experience of a BAME member of staff and the experience of a white staff, the trend might be going in the right direction, but when you've got a disparity of double the experience or half the half the number of people feeling that we're supporting them, that's not good enough. So I think that these are the two where it's great, it's going in the right direction. It's great that we're below average, but actually that's still not good enough. So there are definitely areas. None of this, it's a fine balance for me, the staff survey, which is we absolutely want to recognise that we're a good organisation and our staff are telling us that through this. But let's not kid ourselves that everything is perfect and that the experience is where we want it to be all of the time. And so we've got more work to do.
Yeah, thanks, Caroline. And that's exactly the balanced view I was hoping to hear. So that's really helpful. Thank you.
Yeah, I think in that final sentence, Caroline, you summed it up. And I'm pleased you mentioned people with protected characteristics, because and give us some assurance that we are keeping our focus on that as well. So thank you for that. Leslie, you can have the final word on this.
Thanks, Peter. Caroline, I think you've partly answered my question, actually, because it was looking forward to, we've got the results now, so what do we do with them? And I absolutely see that you're going to put them out to the various areas and have those discussions at team. But I was wondering if there were themes that we need to pick up as a trust as a whole, that would either come up from the teams and be generally amalgamated, or have come through as obvious ones. And I think you've partially answered that question anyway. So.
Thank you. I mean, I think what I need to say is that we've had the results, not the national results, but we've had the results from our supplier for some time now. So we get them in January and use and share them with the teams as soon as we get them. So we don't wait for March and the embargo to be lifted to use the information internally. I've had, for example, in my own directorate, we've done a big exercise of listening to all the staff in HR, OD and comms and all the other areas that I look after. We've done a listening exercise to understand the experience of staff. I know Kate has done the same with her areas of really disseminating the information so that teams own their own results. And I'm meeting with the staff networks chairs in the next few days to talk about the results by protected characteristics. So the work starts almost as soon as we finish the work starts straight away, but obviously now we can see what's happening nationally. So anything else that comes through from those discussions locally will form part of the work that we're going to be doing trust-wide.
And Caroline, have you identified any teams or areas where the results are out of kilter with the whole trust that need potentially a more specific focus or more specific help? Have you been able to do that through these results?
Yes, so the report that we get from our supplier at the end of December, early January, gives us a dashboard that identifies, it's RAG rated, so you know exactly what area you should be focused on. Bear in mind they are outside of the norm, or their results are significantly lower than the rest of the trust. So all that work is already happening, and the HR business partners are working with all the areas and corporate services to work on that. So that work is ongoing.
What would be really helpful is to possibly overlay some of the quality data on that as well and see if there's a correlation too. Yeah. Thank you.
Yeah.
That sounds like a really good point, Leslie. Let's follow that up. And also, Caroline, maybe through the People Committee, once you've been able to collate all those local action plans, if there are any general trends or points you think we need to address as a board, then through the People Committee, please bring them back to us. And well done, everyone, on bucking the trend on the staff survey. And I don't know what target you're going to get next year for response, but
don't worry, somebody knows what target we're going to get next year. Yeah, I'll give you one guess.
Yeah, I'm sure Siobhan's got a figure in mind. But we'll leave it there, shall we? Move on to finance. And Mike, if you could tell us about this.
Thank you, Chair. As the board can see, in terms of our income and expenditure targets and surplus, we are heading still towards a forecast surplus, and we're steadily achieving that in the month reported here, January, expecting to go forward for the 200k surplus previously reported to the board at year end. That's a 200k surplus, which is a manageable variance. Our target is break even, i.e. we spend as much money as we get in. We got considerable amounts of additional funding in the last few months of the year, and so that makes that already difficult challenge even more difficult to exactly spend every pound that we get in. We have in excess of 300 million income in the year, and so landing on that point and spending exactly 300 million is a challenge. 200k surplus is in the right direction. It's better than a 200k deficit, but any variance is kind of investigated in the current financial architecture. We're not reporting any significant material risks that would blow us off course now for year end, so that's great. The other parts of the report worth noting, as you can see, our payments to suppliers has gone off after some good improvement in the latter half of the year. This is mainly down to some issues that our financial services supplier have been experiencing. SBS Shared Business Services, they experienced some problems in their central processing team in terms of scanning invoices in time. If they're not scanned in time, this metric is kind of very sensitive to kind of delays of days on invoices being available, and there was some kind of backlog that they had to deal with nationally. We were actually not one of the worst affected trusts, but it has had the impact you can see here on our payments to suppliers. It's beginning to improve, so we're hoping to be able to improve to report an improved metric when we see this again over the next couple of months. And then lastly, to note the agency spend, the trend is all too obvious. When you look at the SPC chart against agency, it's been increasing and increasing. It's a number of factors that have caused that. But some of the factor links back to that income that I told you about. We were given additional income in the latter part of this financial year to do things like catch up on waiting lists, increase flow across services. That income is non-recurrent in nature and therefore leads you to need temporary staff enabled to spend that income. And some of that temporary staff ended up being agency staff. That's not the entire cause, though. The other causes have been obviously increased sickness at times over the winter, and then also making sure that we covered some long-standing gaps where we've had hard to recruit posts, again, to ensure our services are sort of access, patients can access services, that we can treat, and also we can play our part in a wider system in terms of patients flowing through the system, discharged from hospital, or avoiding being admitted into hospital. So all of that has meant this increase, reasonably steep increase in agency spends compared to previous years. We are, and Kate is leading a piece of work, getting underneath that and making sure that we go into next year with the appropriate use of temporary staff. We're not going to eradicate agency usage. There is an amount of agency usage that is the right amount for us, but we are moving towards a stage where we can reduce this and want to see it at lower rates during next financial year. If there was a spotlight I would write, I guess there would be an update on what next year looks like, but I can't really write anything down. It's very much in flux at the moment. We have some risks to delivering a balanced financial position, and there are risks across Sussex in the tens of millions in terms of yet delivering that balanced position. Most of our risk sits around additional investment and whether we can secure that additional investment to either expand services as the aspirations either within Sussex plans or the long-term plan state, or deal with some of those built up waiting lists that we've spoken about. If the income isn't forthcoming, then we'll have to manage our cost base. The risk then will be, can we cut that cost base appropriately in time? The second risk is obviously a patient risk. Can we reduce those waiting lists as rapidly as we want to? That's a risk at the moment. It's not crystallised. More information coming back to the board when we look at our plans for the year in April. We're due to do that, and we can have a broader discussion then about how some of that risk may or may not have crystallised, and what our choices are as a board in terms of financial balance and patient access and patient treatment. But it's a difficult issue, and it's an issue that's been experienced not just across Sussex but across the country in terms of the finance being tighter going into next year than we've experienced over the last couple of years.
Okay, thanks for that, Mike. You preempted my question. Just for perspective, 200,000 on an income of 300 million is less than 1/10 of 1%. Mark, Resources Committee's looked at this. Anything you want to add to what Mike has told us?
I think Mike's given you a very fulsome update. In Resources, we had the benefit of seeing month 11, and so we continue on the glide path, and we had assurance around where we plan to go. And just to reconfirm, Kate will be bringing a deep dive on agency to us, I think in May now. So it's an area that we're keen to understand and recognise where good agency spend is occurring, and perhaps where not good agency spend is occurring. And from a planning perspective, I think from the board clearly needs to understand where we're landing and how that manifests itself in terms of the challenges on service, and we'll bring that back in April.
Okay, thanks for that, Mark. Any further questions for Mike? No. In which case, I'd recommend that we note the IPR and the actions already outlined, and I'll move us on to committee chair reports. And the first one,
Peter, David's. I can see David has.
David,
might be able to see it. David's hands up.
Well spotted.
Sorry, Peter, I couldn't put my hand up fast enough before you moved on. It was related to Mike's report. It was something more in general. There used to be a requirement in the IPR that we had to talk about risk, particularly digital risk, even if we didn't have any. There was if you recall, we were required by the national folks that we had to make that rather pointless statement, but we had to put something in the IPR. I just wanted to check that requirement has now disappeared, since I'm mindful that for a couple of occasions we haven't put anything, we haven't put that sort of negative statement in.
Yeah. Zoe, you can answer that one.
It doesn't go in there now because the risks now, the escalated risks come through the BAF on a quarterly basis. It doesn't go through the IPR as a matter of course unless there is an escalated risk. So we don't make a statement monthly that says there aren't any, but if there were any, they would be reported through the IPR.
Okay. I'm perfectly happy with that. If that's is now the requirement, that's fine.
We do normally have a note of any operational risk extant at the time of the board
Yeah.
meeting. Is it above 15?
Yeah.
So, and I presume the fact that nothing is mentioned in this report means there are no such risks at the moment, Siobhan?
That's right.
I might ask Kate to answer that question, but I just wanted to, I think we need that slide back in the IPR to give you positive confirmation, even if there isn't a 15+ risk, we tend to have it. I just wanted to touch on the spotlight reports to just ask the board's view. We had a conversation as execs yesterday about whether, as a matter of course, board members would like to see a spotlight report in each of the sections or not, and whether they would only like to see a spotlight report at the discretion of the execs. My view is I think it's a worthy part of the discussion of the IPR, and I would rather we consistently apply the spotlight report. I can see people nodding. Shall we take that as affirmation that we should have a spotlight report for each section? Because there are some forward view conversations that I think, as Mike's just said verbally, Donna said verbally, there's some topics of the moment that I think are worthy of conversation, and if we have spotlights as a matter of course, it enables us to do that. So I just wanted to check that with colleagues. Peter, Kate, did you want to answer about this 15+ score risk scores?
Yeah, so I will always add 15+ operational risks into the my section of the IPR, but apologies, that's an oversight. I should have made a statement that there weren't any, so that you didn't think I'd just missed them out. I'll make sure that's in the future papers.
Okay, that's fine. David, did you want to come back, or is that a legacy hand?
Oh, sorry, I thought I'd put it down.
That's okay. Siobhan, you got some nods there. One of the things Mike said at the beginning of this was that we should be looking to further develop the IPR, and perhaps that's something we can flag up for maybe if not the next board meeting soon, and we can bring into that discussion a spotlight report to make sure it's achieving its objective. I find them very useful, but I don't want people to write stuff just for the sake of it. So I think it's about how we get that balance. So that's a good point. Thank you for that. And let's move on, shall we, to committee chairs' reports. And the audit committee's first up, David. You've said there's no issues to be escalated to the board. Is there anything you want to say by way of commentary?
I think what I was going to say was to say that the focus of the audit committee at its last meeting was particularly around year end, and we heard from the external auditors on their plans for their year end audit, and they weren't flagging any particular issues that we needed to be aware of at this stage. We talked to internal auditors about their head of opinion that they give at the end of the year, and there was no particular issues there for them to flag. And we specifically looked at the year-end accounting policies and the going concern basis. So we essentially focused on the year-end. We also focused upon looking at the planning for next year, and we looked at the internal audit plans, the counter fraud plans. And so we have a holistic view on audit plans. We briefly looked at clinical audit, although we were mindful that that was being dealt with in more detail at the Quality Improvement Committee. So those are the major sort of themes that we talked about.
Okay, thank you for that, David. Anyone have any questions for David? So shall we note that report and move on to charitable funds? Rebecca, you had a meeting on the 15th of March.
We did, thank you. Yeah, nothing for escalation to the board, just some points to note really. We've made some positive progress on both of the balances that we're holding for Chailey and Midhurst. So we've agreed approval for a staff wellbeing, some initiatives to support children and young people and their families, and a sensory garden at Chailey, which is fantastic news. And then we're also exploring potentially looking at the creation of on-site accommodation for staff to help with some of the challenges that we've had there, both in attracting and retaining our staff there. So we're just doing an audit and a needs on whether this would be used and wanted and what the costs might look like. With Midhurst, we've agreed that we're moving forward with a couple of our ideas which have been discussed at these board meetings previously, but also exploring, importantly, a new venture with a third sector organisation which would benefit the local population. We approved some other funding, and then the last thing to mention was just really on the budget proposal for this new financial year that we'll be going into. We just asked for a bit more of a focus around some of the costs, just with regards to rates of inflation for meetings, travel costs and so on, where we thought it just needed increasing slightly, but nothing per se to escalate to the board.
Okay, thank you for that, Rebecca. Any questions for Rebecca? In which case, we note that, and it takes us on to the inaugural meeting of the People Committee. Giles.
Thank you, Peter. I think the report is pretty much as read. We've covered off bits as well as we went through the IPR. I think one of the bits probably just to raise for this committee, which is of interest, is that Kate is probably the envy of the rest of the execs as she attends all of these committees and is probably the only person to do so. But I think it's very incumbent necessarily on her that we don't burden the exec team and the organisation with trying to deliver the same report time and again to 3 different committees, and just to try and coordinate between it. We drew that through with safeguarding, FTSE, and making that a priority reporting through to Quality Improvement Committee, and accepting referrals that may come out from that into the People Committee as well. So just trying to streamline it with a view to the exec and working between all the committees to ensure that we're cited on what each other's doing in a coordinated way, not a duplicating way.
Yeah, no, that sounds a very good point, Giles, and we don't want to create extra work for anyone, including Kate. Any comments on the People Committee summary? No? Which takes us on to, I think, Quality Improvement Committee next. Leslie, we've touched on some of this already, but please give us your commentary.
We have, and obviously some of the papers following were covered as well and seen in quality. There's nothing to escalate to the board, but just 3 things I want to just highlight. The first was around falls in inpatient units and how the different rates across East and West Sussex are quite significant. We've asked for a follow-up piece of work around that, and the Falls lead, I believe, is doing some work, and that will come back to QIC. So obviously we'll bring that back to board if there's anything significant coming out of that as well. Quality account, we saw an early draft around priorities, and again, just assurance for the board that that work is in progress and will be ready to be received by the board in June, I believe. And because it's been a topic for some while, we had an update around community nursing and the work that's going on there, and the various strands around demand and capacity, and some of the work that's going to allow us to benchmark with 6 other trusts, which I think is going to be really useful work. There's been a new Queen's Nursing Institute report, which again we've been looking at, and these will tie together with the work around deferrals and triage and caseload management. So the whole thing will be brought together, and hopefully we'll have some more outcomes at our meeting in May. Happy to take any questions.
Thanks for that, Leslie. And community nursing, of course, is a very important service to us, and it'll be good to get some oversight of how that work's going in the future. Any questions for Leslie or comments? No? Which takes us on to Resources Committee. Mark, there are 2 summaries here, the last of which was the meeting you had last week on the 22nd of March.
Yeah, the 2 summaries, Peter, because obviously they're the 2 meetings we've had since the last public meeting. I think the items for the board from the February report were dealt with at the February board meeting, the Digital Aspirant Plus and the Links Road GP premises, both of which were approved. So nothing really more to add on that. And then in relation to March, that's the latest financial position, which doesn't yet appear in the board IPR reporting, but we've discussed that already. And as has been signalled, the planning process is ongoing with a further update next month. So nothing particularly to add, and happy to take any questions.
Okay, thanks, Mark. Any questions for Mark? No. In that case, we receive all those reports, and let's move on to item 6 on the agenda, which is the Guardian of Safe Working. And so are you going to give us an update on this, which refers to our junior doctors?
Yeah. As you are all aware, there is a requirement from the 2016 junior doctors contract that there's assurance to the board of the trust arrangements for the safeguarding of our junior doctors' hours. We only have at the moment a maximum of 5 junior doctors that we directly employ, although we have a few others who are employed by other organisations and do secondments with us. So for Q3 of 2021-22, there were no exception reports for hours worked or for missed breaks or for missed educational opportunities by the 4 trainees that were in post at the time, and therefore no fines have been levied against the department or the trust. And just interestingly, we run a junior doctors forum as well. And the junior doctors reported that they all felt very well supported by they're all paediatric trainees, but by the teams that are supporting them.
Okay, thanks for that, Sarah. Any questions about the welfare of our junior doctors? No. In which case, I ask us to note Sarah's verbal report and move on to the mortality report. And Sarah, you're in the lead again.
Yeah, okay. So this is a summary of the mortality reviews that were done in Q3. As usual, all reviews were done using the Royal College of Physicians structured judgment forms. There were 15 deaths during that period. The age range of the patients that died was between 70 and 99, with a mean of 86.6. Most of the causes of death were cancer, frailty, infection and stroke. There were 5 deaths in which COVID was either the causal factor or a contributory factor to death. And in one of those cases, the patient had a hospital-acquired COVID-19 infection, so that has been investigated as part of an outbreak serious incident review, where we actually reviewed the 3 deaths during that particular outbreak, 2 of which were deemed not to be were related to other underlying conditions. For example, one patient had metastatic liver cancer, and COVID-19 contributed to the death rather than caused the death. And I think that was all I was going to say. And there were no, so that case was discussed with the coroner. Okay, and that was all I was going to say.
And thanks to Vivek Patel for the usual comprehensive report. Any questions from board members? David.
Thank you. Just a brief question. On section 2.5, we note that one patient was transferred back to the acute. And I guess that I'm conscious it's only one patient, but I just really wanted to check that there was nothing around inappropriate transfer to us in the first place, and whether that mechanism for transfers was working satisfactorily.
I think it's very difficult to really, so everywhere is under extreme pressure, and partly because of the pandemic and partly because of the kind of huge numbers of attendances at A&E, partly because of the numbers of patients who were waiting to go to a care home or get care packages. So the whole system is under extreme pressure, and I think as you can see from the SI report, there are a few occasions where patients have been transferred where that the acute trust didn't completely follow the criteria that they were supposed to follow in terms of swabbing of patients, etc., for example, for COVID. So, but it's a kind of balance of risks, and I think we've got to try and do what's overall the best for all patients. So I think things aren't always perfect in terms of the patients that are transferred, but also we also know that the types of patients that come to our unit tend to be elderly with lots of comorbidities, and that by virtue of that fact, it would not be unexpected that someone might deteriorate whilst they're with us.
Okay. Mark, you want to come in?
Yeah, thanks, Peter. Thanks, Sarah. Just one line caught my eye on page 58 under section 2.8, where you talk about the standard documentation, and it says it's excellent in 2, good in 5, and average in the rest. And I just wondered what the expectation that you had for documentation. I didn't know whether that was satisfactory from your perspective or not.
I guess anything that's average and above would be satisfactory, and that relates to various things that have to be documented in relation to what's on the SJR, the RCP SJR form. So it kind of relates to what has actually been documented in relation to that form.
Okay, so everything's at the level that you're expecting.
Yeah.
Okay.
Yeah.
Thank you.
Yeah. Okay. And your point about inappropriate transfers, so what you're essentially telling us is the pressure on services increases the risk of the potential for inappropriate transfer, but there's not a general trend or a problem there as far as we can see. We haven't changed our criteria or anything like that.
Yeah, yeah. So yes, I think it's not so much inappropriate transfer. It's just sometimes not all of the I's and T's are sort of dotted and crossed in quite the same way that they would be when the system's under less pressure. Okay.
Yeah. Thank you for that. And are we happy to receive the mortality report? Yeah. Which takes us on to serious incidents. Now, Sarah, this has got your name on the bottom, but my agenda says that Donna's going to introduce it. So
yeah, no, it is normally me. So I
thought it's normally you.
Yeah. So if you don't mind, I'll introduce. I know it gets a bit boring just hearing me droning on, but if you don't mind, I'll present it. So this is again the Q3 SR report, which has already been to the Quality Improvement Committee. As you can see, there were 5 serious incidents in Q3 and 11 further incidents that had an in-depth root cause analysis. The SIs were 1 patient with a pressure ulcer and infection where there was a failure to escalate by the community team. There was 1 child with a missed testicular torsion. There was 1 patient that deteriorated in one of our intermediate care units where there were concerns regarding nutrition and hydration. There was 1 patient where there was a sudden death that on post-mortem showed that the patient had a heart attack, and we've requested for that to be de-escalated because it's just something that couldn't have been avoided. And then there was 1 COVID-19 outbreak, which I've already discussed in the previous report, where 1 of the patients had a hospital-acquired COVID infection, where it would appear that there has been suboptimal care of that patient in terms of care planning more than anything else. So that there wasn't a treatment escalation plan in place about whether or not the patient should have been escalated back to the acute trust, although that patient did have significant comorbidities and hadn't been making progress in their rehabilitation whilst they were with us. Then in terms of the root cause analyses that were the other 11 root cause analyses, there was some learning from those. And again, as I've alluded to, with some problems with patients discharged from the acute trusts, mainly around not providing all of the information that was required, and in relation to outbreaks that not all of the transfer guidance was followed, particularly around the requirement for a swab 48 hours before transfer. There was 1 case where 2 doses of insulin were given to the same patient on the same day in relation to how things were documented, but there was no harm for that patient. and we just noted that the podiatry team hadn't been following the missed visit, the no reply to a visit policy in exactly the way as it had been written. Then within the report, there's also a brief update on the changes to the National Patient Safety Strategy. And then finally, there were 5 RIDDOR incidents reported, and these were 3 falls at Crawley Hospital, which have been raised with NHS Property Services, and then 2 other falls, one which was on the Brighton General Hospital site and one which was a member of staff who was in a public place when they fell. Any comments or questions?
Okay, thanks for that, Sarah. Leslie, the Quality Improvement Committee's had a look at this. Anything you particularly want to raise?
Yeah, I mean, one area we were concerned about was the number of deteriorating patients, of course, but got assurance from the action there. We did have quite a discussion about the format of the report and not so much the SI section, but the patient safety incidents generally, and around what's coming up as the key issues to look at. So but potentially, you know, things like falls and deteriorating patients should be heading in that category. But Donna and I are going to have a further conversation about that. And
so we're going to look at how we improve that part of the report in the future. So you and Donna are on that. That's good. Any questions from board members about the serious incident paper? No. In which case we will receive that and move on to item 9, Local Clinical Excellence Awards. Again, this is yours, Sarah. Can we just say that we have very little room for discretion on this, and that the agreement essentially between the Department of Health and Social Care and the BMA gives us little wriggle room. So we've basically done what's been asked of us. Is that a fair summary?
Yes, we have. So I don't know whether some members of the board may not know about Clinical Excellence Awards, but they're part of the terms and conditions of the consultant contract. What normally happens is that there would be the consultant staff would be notified that an awards round was opening, and that they would have to fill in a form which described where they thought it's a prescribed form that they would fill in, where they would describe where they had achieved over and above what would be expected of them. Because of the pandemic, decisions were made in the last 2 years that rather than, because it's onerous to fill in the form and also onerous to run a panel, that the awards should be equally distributed between all eligible consultants, which is what we have again done this year. And as Peter says there, we've just gone along exactly the lines of what we have been told to do by the national teams. So there are 29 consultants and 27 eligible. So the people who aren't eligible are consultants who've been consultants for less than a year, and anyone who already has 9 Clinical Excellence Awards or a national award. And just the other thing to note is that this was part of a temporary 4-year arrangement, because the old awards are different to this current set of awards, and the arrangements for 2022 and 23, there'd been negotiations around this with the BMA, and there hasn't actually been agreement about what should happen going forward, but we will be going back to a panel format where we're given some guidance and as how that should run for 2022-23.
Okay, thanks for that, Sarah. And it's a national requirement, isn't it, that this is brought to the attention of the board, even though in normal years it's the panel that decides who gets what. Okay, Giles, you want to come in?
Just a quick one, Peter. If a consultant is part-time, is it given out pro rata? Is this, if it's not, this would suggest that all the awards are full-time.
We had a discussion about this, didn't we?
Yeah.
Essentially, Sarah Siobhan and I had a look at this, and this question was raised. And on balance, I think we decided to give everyone the same amount, despite whether they work full-time or part-time. Is that so? Are you?
Yeah.
We can extrapolate on that and expand on it, but that was a point of debate and discussion, wasn't it?
Yeah, that is the national guidance, because you're no less excellent just because you work part-time, and I think it would unfairly discriminate potentially against women if if you did do that, and so we've just followed national guidance.
But it was part of the discussion, Giles, just to reassure you on that point about how best to do this and whether to question the national guidance we received. Any further questions on Clinical Excellence Awards? Okay, in which case I will move us on. Before we finish, put you on the spot, Siobhan. We had you held a North Staff webinar last week, I believe. Third of a series. I just didn't know if it would be helpful to board members to know how that went and what your plans for the future are around that.
Thanks, Peter. Sorry, you caught me being distracted by a mild, well, not mild, a snowstorm in Brighton as I looked out the window. So yeah, I mean, so the first thing to say is, you know, we've got a new associate director of communications who's joined us this month, and I met with Chris Walker yesterday to talk about our future plans around engagement across the trust. So we've done 2 all-staff webinars this year. The one in January attracted around about 200 attendees. The one that we did last week attracted about 65. Now that's still a meaningful dialogue, but I think that we probably want to seek to understand from our people what a effective way of two-way engagement looks like as we move into the rest of 2022. So the positive about an MS Teams live event is that there is no maximum number of people we can reach. The slightly less positive part of it is that we don't see people's faces. People interact with us through a chat box or a question and answer box. So it does serve a purpose. And I think in the midst of the pandemic phases, where we've been really keen to sort of transmit information, I think that webinar format has worked really well. What I said to Chris yesterday is he and I need to work together to do a bit of intelligence gathering from our teams and our people to say, how do you want to hear from the exec team? How do you want to hear and see the chief executive as we move forward? And what are the important subjects that you want to hear about? So I think what we're going to do is kind of put a bit more evidence behind the content and the methodology that we use as we move forward this year. It's always really great to hear from our frontline teams. You know, what did we hear about? We heard you know, people's kind of concerns about cost of living increases. We heard people's concerns about, at that point, not knowing whether they would have to pay for lateral flow devices. Of course, as we said earlier, that's changed now. We heard from some students on placement with us, which was lovely. We heard from 2 physiotherapy students from Chichester University who were out with our teams in West Sussex, and they actively engaged in the dialogue with us. We also heard that some people are finding it difficult to find a route to return to clinical practice when they've stepped away from it. So, you know, there's always really important pieces of information that help us to inform improvements for the future. I think what I don't want to do moving forward is solely rely on the methodology that we've used for the last 2 years to connect with people. Prior to the pandemic, the exec team used to go out and about into different sites in the trust. We used to invite people in to have dialogue with us. I think somewhere between that, which used to generate quite low numbers, and the sort of version of the webinars where we get 200 people, somewhere between the middle, I would like to have really meaningful engagement some face-to-face, some using the digital technologies that we've got. So I think Chris coming in and heading up our communication engagement function gives us an opportunity to rethink our approach to engagement moving forward. We will definitely be seeking people's views and engaging in new ways this year. I think it's really important that we do that. And when the community transmission rates come down and it's safe for us to get large groups of people back in a room, that's where I get really excited about the energy and the networking that happens when you bring a bunch of people together to have conversations, and they're so rich, I don't want to lose them in entirety. But of course, always really incredible to hear what's on people's minds, and so we'll continue with that spirit, but probably just change the engagement approach as the year unfolds.
Okay, thanks for that, Siobhan. That's really, really helpful. And finally, Zoe, did we have any questions we need to answer that have come in on the live stream today?
None that have come in on the live stream, Peter.
Okay, thank you for that, Zoe. So I'll finish by thanking Steve Jones for running the live stream and thanking you all, and remind you that the board will reconvene in part 2 session at 12:30. In the meantime, enjoy your lunch. Bye for now.